What is erectile dysfunction? So erectile dysfunction basically is the inability to maintain an erection. I always tell guys erectile dysfunction is not necessarily not being able to have an erection at all, but it's actually not being able to have an erection that's satisfactory to a patient's needs or desires. Meaning, if you have an erection that's not necessarily rigid enough for penetration, if it doesn't last as long as a man wants it to, that's considered erectile dysfunction, which is important to note because I think a lot of guys do feel like erectile dysfunction is when you don't have any function at all, which is not the case. The other thing that's important to note that is erectile dysfunction is actually quite common. So 1 in 5 men that are 20 years or older get erectile dysfunction. There's an interesting statistic where I always say 50% of men that are over 50 years old have some aspect of erectile dysfunction, and actually up to 40% of men 40 years or younger have some aspect of erectile dysfunction. And again, that's important to note that it's pretty darn common, and it's something that affects quite a few men. Almost 40 million men, American men, suffer from some aspect of erectile dysfunction. So I think, again, that's something that's quite important to note in terms of how prevalent it is. And so, in terms of erectile dysfunction or how it works, basically the process, to go from flaccid to erect, as you can see in these pictures, without going into too much detail, in these cylinders, the eyes of the bug, if you will, it looks kind of like the penis there on the right looks kind of like a bug. Those are where all the blood vessels are. And so then whenever a man gets aroused, those arteries, those blood vessels all dilate. There's relaxation of muscle in the arteries. The dilation of those blood vessels into the artery, into the penis, causes the penis to get stiff. There's veins in the blue around the blood vessels there in the red that you can see. Those veins compress. So the artery dilates, the veins compress, not allowing blood to leave the penis. And that causes you to get an erection. And so as you can see on the picture on the left, the arteries are not dilated, the veins aren't compressed. On the picture on the right, the arteries are dilated, these veins are compressed, giving you an erection. So oftentimes the issue is not being able to get enough blood flow to the penis for different reasons, in terms of not being able to get the artery to become dilated enough to compress those veins. So that's the idea of not being able to get a good erection. Again, flaccid on the left, non-dilated arteries in the middle of that, the eyes of the bug, if you will. And on the right, everything is dilated. The veins, the blue on the outside is compressed, giving you an erection. So causes. So erectile dysfunction doesn't come by itself. There's always some kind of cause. The most common causes are some kind of vascular issue, meaning something that's not allowing the blood to go to the penis. That includes things like heart disease, hypertension, high cholesterol, things that are going to clog up the arteries. Diabetes is another big reason. So diabetes in and of itself causes not only vascular issues, meaning issues to get blood flow to the penis, but also it causes neurologic issues. So it can actually affect the nerves that help with stimulation to the penis. And then medications. There's different medications that can cause guys to get issues with erectile function, including some hypertension medications that are pretty common, amongst other things. The other important thing to note is prostate cancer treatment can cause erectile dysfunction. So guys that have had prostate cancer and are getting treatment with either surgery, so the prostatectomy, taking the prostate out, or brachytherapy, radiation seeds, cryoablation, freezing of the prostate, or even just plain radiation therapy, all of those can affect the nerves to the prostate, which can cause erectile dysfunction as well. And another important thing about overall the general erectile function is erectile dysfunction, again, like I said, doesn't come just by itself. Usually erectile dysfunction isn't this diagnosis that's solitary. There's something that's causing it. And so whenever a guy does have erectile dysfunction, it's very, very important to get the erectile dysfunction treated, but also to ensure that if you don't have a primary care physician, to go to a primary care physician to get a workup to make sure you don't have things like high blood pressure, high cholesterol, diabetes, and to make sure you get those things treated, because oftentimes just by treating what's causing the erectile dysfunction, you can treat the erectile dysfunction itself, like treating the diabetes, treating the hypertension. So erectile dysfunction, obviously is an anatomic issue, not allowing blood flow to the penis, but it can have a pretty negative effect on quality of life of men. And that seems obvious, but I think it's important to take a step and note that erectile dysfunction really does mentally affect a lot of guys, because it's a real big part of what's been your, potentially daily, weekly life of having an erection, having one that's rigid for intercourse. It has to do with, or it has oftentimes a big part to do with relationships and things of that nature. So again, erectile dysfunction not only is a physical diagnosis of not being able to get an erection, but also it affects a lot of different things in a man's life. So diabetes, over 15 million guys, men in the United States have diabetes. And diabetes is super important because of three things. Because people that are diabetic usually are less likely to have good responses or as good of a response to things like Cialis or Viagra as men without diabetes. Usually men with diabetes have more severe erectile dysfunction, and oftentimes erectile dysfunction is the presenting symptom of diabetes, meaning some guys will get erectile dysfunction and then find out they have diabetes afterwards. So again, erectile dysfunction is important because it can be potentially a precursor or a potential first diagnosis of some other etiology, again, like hypertension, diabetes, heart disease, etc. And so, reasons, again, why guys with diabetes have erectile dysfunction, again, nerve damage, the damage to the arteries, and not the big arteries like arteries that are taking blood from the heart to, let's say, the brain or legs, but the smaller arteries that are taking blood flow to the penis are oftentimes more likely to get some blood flow issues, cause erectile dysfunction. And so the idea of treating erectile dysfunction in guys that are diabetic, if those nerves are damaged, if the arteries are damaged, sometimes the pills don't work as well as they would in somebody that has, let's say, other etiologies of erectile dysfunction. So again, diabetes is an important etiology of erectile dysfunction, but it can change potentially how severe a guy's erectile dysfunction can become. And so just like this says, the pills that treat erectile dysfunction need the nerves to be intact and the blood vessels to be intact. And kind of like I talked about before, erectile dysfunction can affect not only the nerves that stimulate erectile function, but also the blood vessels. And so the pills potentially aren't as effective for those men. And it's important, again, I know I'll keep harping on this, but to get the diabetes treated to ideally help to improve the erectile function potentially. So things that can cause more potential severity of erectile function are age, the severity of the diabetes itself, overall vascular disease, how bad the blood vessels across the body are treated, and then heart disease, diuretic treatment. So overall, there's different things that can cause some more severity of ED. And going right into heart disease with erectile dysfunction, kind of the same situation with heart disease in terms of potential higher severity of erectile dysfunction. So there's studies that basically show that men with coronary artery disease, so men that have basically what's called atherosclerosis or obstruction of the coronary arteries, of the heart arteries, those guys are more likely to have worse erectile dysfunction. And erectile dysfunction oftentimes is a precursor, again, to coronary artery disease. And kind of this is going to come up over and over in this talk, but erectile dysfunction, when a guy starts to have issues with erections, it really is oftentimes a precursor or a sign that there's something else that's going on. And so symptoms of heart disease, oftentimes it can take 2 or 3 years of having erectile dysfunction prior to having that ED, meaning symptoms of heart disease. A guy oftentimes is diagnosed with heart disease, whether they're having some chest pain or some other issues on an EKG, about 2 or 3 years after they start having erectile dysfunction. So again, not to harp on it too much, but it's important. It can be a precursor of other etiologies. And so the reason that it's going to happen prior to diagnosing heart disease, meaning the reason that ED happens prior to heart disease, the blood vessels are smaller. And kind of like I mentioned before, with heart disease and with overall vascular issues, the blood vessels that are bigger have a little bit more time prior to being affected by a lack of blood flow. However, with the penile arteries, you can see here, it's a lot smaller than these other important arteries. And so the penile artery is going to be affected, meaning the erectile dysfunction is going to come up prior to a man having symptoms or having bad enough obstruction to the artery to the heart for it to cause issues. And as you get bigger and bigger, the internal carotid is the artery to the head, the femoral is the artery to the legs. Those are going to be affected much later on. And so again, erectile dysfunction, once it comes up, definitely get it treated, but try and get what's causing it to get treated so that you don't have the issues of the heart, of the artery to the head, the carotid, the femoral artery, things of that nature. And so again, here this alludes the same fact. So risk reduction. So the important things with erectile dysfunction and improving heart health, of course, you hear every doctor say it, but really make some healthy life choices: diet, exercise, weight loss, smoking, big one, smoking. It's a huge risk factor for really kind of all of the above in terms of risk factors for heart disease, diabetes, cholesterol, everything that kind of can preclude you to having X, Y, and Z. So So testosterone. So this is an interesting part of erectile function that guys think about, but don't necessarily think about, if that makes any sense. So testosterone is more common in men that have things like diabetes, obesity, high cholesterol, high blood pressure, as well as COPD. Testosterone and erectile function, I always tell my patients, they go hand in hand. So a guy that has erectile dysfunction and a guy is much more likely to have low testosterone than a guy that doesn't have erectile dysfunction. And kind of the opposite is true. So a man that has low testosterone is more likely to have erectile dysfunction than a man that's got normal testosterone. But it's important to note that because those two go hand in hand, oftentimes one of the presenting symptoms of low testosterone is erectile dysfunction. So a lot of men that come into my clinic, I actually do check a testosterone on those guys to make sure that the testosterone level is appropriate if they're having erectile dysfunction, because erectile dysfunction can be multifactorial. A few things can cause the erectile dysfunction to come about. And so as you can see on the right, there's quite a few men, 4 in 10, up to 40% over the age of 45 that can have low testosterone. So it's something that's important to check. Treatment options include things like gels, patches, oral medications, and injections. And there's some potential factors that come into play with that discussion of a man having testosterone or low testosterone and getting testosterone replacement therapy with the gels, the patches, the injections, etc. But it's a conversation that's important to have. And so erectile dysfunction and prostate cancer treatment, this is a big one. The reason behind this is because whenever a guy has prostate cancer, you can see in the picture here, the cut that you make to take the prostate out is pretty close to not only the urethral sphincter, but also below that in the yellow is the neurovascular bundle. We do everything we can to preserve the neurovascular bundle, to keep that bundle, the nerves in place and not to bother them at all. But just by peeling those nerves off, a man almost always has some aspect of the erectile function takes a little bit of a hit, regardless of how little manipulation there is of those nerves around the prostate. And so any guy that goes through some kind of prostate treatment, whether it's cutting the prostate out or radiation therapy that can affect the nerves as well, the nerves are going to take a little bit of a hit. And so it can take sometimes even up to a year and a half to regain the erectile function, to have those nerves get healed up. But there are some men, sometimes even up to 40 to 50% of men, that don't regain that function. And so it's important to note that oftentimes you can achieve an erection on a temporary basis for some time after a little time, but you can have permanent potential decrease of erectile function after prostate cancer treatment. And so this talks about the cut that's made and then the urethra that's brought back together during the prostate cancer surgery. And again, it can range from 25 to 75% of guys that have some kind of sexual dysfunction. But again, up to 50% of guys have some aspect of erectile dysfunction after some kind of surgical or radiation treatment for prostate cancer. Prostate cancer is a big part of erectile dysfunction. So Peyronie's disease. So this is an interesting part of erectile function. We'll talk about why in just a second. But Peyronie's disease in and of itself is basically when a man has a curvature with their erection. So when a man gets erect, the penis is literally curved upwards, left or right in some different direction. Sometimes that curvature can cause the erection to be painful, and sometimes the erection can be so curved that it can be difficult to achieve penetration or have appropriate penetrative intercourse. And it can actually cause pain to the partner as well during intercourse. And so Peyronie's disease is important because it's not actually super well known. A lot of guys don't know that having that curvature of the penis is abnormal, but also they don't know that there's potential treatment options for it. I know there's a commercial out there now that has the bent carrot that talks about Peyronie's disease, which is great, which is the awareness has been fantastic in terms of having patients come in and seeking treatment for their Peyronie's. The other important thing about Peyronie's is it's same as erectile dysfunction. It's very, very, it can be anxiety inducing. So not only in relationships with being able to have a good sexual relationship with a partner, with a spouse, but also in general, just to a man that's had a straight penis for their entire life, seeing a penis that's starting to get curved can be pretty difficult to deal with. And so it's something that a lot of guys have trouble with, but don't realize that there's treatment options for, which include injections into that area of scar tissue that's formed, which is what's causing the Peyronie's disease, causing that curvature, doing different surgeries, either application, which is basically where you put a stitch in to correct that curvature, or if you have erectile dysfunction and Peyronie's disease both together, you can actually do a penile implant where we place an implant that you can pump, which we'll talk about, to be able to get an erection, but also treat the Peyronie's disease, the curvature, at the same time. The idea of Peyronie's disease is you have this plaque, this scar tissue that's formed in the penis from some kind of injury, whether a guy remembers it or not, that causes the penis to bend because that area of plaque isn't elastic. It doesn't stretch like the rest of that corporous tissue, the area of the penis that has blood flow. So when those blood vessels dilate, everything else dilates around it except for this plaque. And the problem with that is then you get curvature because that one spot isn't as elastic as the rest. I compare it like to having a scab on your skin. Your skin is nice and mobile normally. When you've got a scab, that skin's not super mobile anymore, and that plaque is the exact same. So with the treatment options, the idea is to try and disintegrate that plaque as best as possible. But the issue is with Peyronie's disease, as you could potentially imagine, if you've got that plaque there, you're not having that elasticity. You're not having that blood flow that's able to get all the way through the penis as well anymore. So you can get guys that have erectile dysfunction very often when you have Peyronie's disease as well. So oftentimes you have erectile dysfunction and Peyronie's disease that happens together. I spend a little bit more time on this page just because I know there's a lot of patients that do have Peyronie's disease as well as erectile dysfunction that don't realize that A, they go together often because of the etiology of the disease, but B, because there's treatment options for both of them, potentially even together with an implant. And so, again, I apologize. We talk about the scar that's involved there, and then the reasons why it's important to treat because of the curvature, but also because of the potential erectile dysfunction, and actually because of the potential loss of penile length as well, due to the fact that the plaque doesn't allow the penis to dilate. And again, the treatment options include that injection that we talked about. So what's called Xiaflex, an injection directly into the plaque that can disintegrate the plaque if you have decent erectile function with or without pills, or potentially a surgery, which would include correcting the curvature with a few sutures versus using an implant to kill two birds with one stone to treat the erectile dysfunction as well as the Peyronie's disease. This is an important page that I'm not going to spend too long on, but I want to make it pretty clear. So Peyronie's disease and erectile dysfunction actually can be potentially treated, or there's been studies to look at if they can be treated by three different things: by shockwave therapy, by stem cell therapy, and by what's called platelet-rich plasma, by PRP. There's a lot of clinics across the country that are treating Peyronie's disease as well as erectile dysfunction with these therapies. What I'll say without going into too much detail, shockwaves, so the first one, extracorporeal shockwave therapy, there's some studies that show that there's promise with that treatment option, but there's really only promise in certain types of patients, usually the patients that are having some small amount of erectile function or dysfunction that's really being somewhat managed by oral therapies. If a guy isn't having good function with oral therapy, or if they're just having some issues with maintenance and want a little bit more maintenance or a little bit harder of an erection, the shockwave is not going to work very well. The stem cell therapy and the platelet-rich therapy are pretty investigational or pretty experimental. There's not a whole lot of data yet that shows that there's going to be much of a response from either of those therapies. So it's actually something that I and most men's health specialists don't offer to our patients because it's not covered by insurance. You're paying out of pocket for a therapy that we don't know that's going to help you. And so I think it's important to note, it's important for guys that are out there that are looking for alternative therapies to know that you may be spending a good amount of money on these therapies and they may not do a whole lot for you. And so I think that's a very, very important slide and important thing to note from an erectile function treatment standpoint. So options for erectile dysfunction or treatment options. There's oral medications, so the things Cialis, Viagra, Levitra, Stendra. Those are the main four that guys have heard of. There's different ways that you can take them, including taking them daily versus taking them as needed. There's injections. There's the vacuum erection device. There's urethral suppositories, and there's penile implant. We'll talk about each of these in detail coming up here. So how do the oral medications work? How does Cialis and Viagra work? So the idea is basically they increase blood flow to the penis. So the mechanism of action is essentially they stop a process going to with enzymes that are going to the penis. They stop a process of keeping the arteries from dilating. And so the idea essentially is they keep the blood vessels open longer and open better to be able to get more blood flow to the penis. They're quite effective. They're effective, and oftentimes in patients that haven't taken Cialis or Viagra before, up to 3/4 of patients have some aspect of a response, and that obviously can depend on how severe the potential cause of the erectile dysfunction is, meaning how bad their diabetes is, how bad your potential hypertension, coronary artery disease, etc. But overall, it's important to note that they're pretty darn effective. Viagra in particular can be affected by food intake. And so usually we tell guys, if you're taking Viagra, to take it on an empty stomach because it's going to be much more effective. Cialis, it doesn't matter if it's an empty stomach or not, but Viagra does. And so that's important. Side effects. So the side effects is an important part of what oftentimes will keep a guy from taking Cialis or Viagra. So the most common side effects are headache. Oftentimes it's a sinus kind of frontal facial headache. Facial flushing is another side effect. Some guys can get a bit of acid reflux or an upset stomach. And then with Cialis, you can get a little bit of a kind of a back muscle spasm. And actually with Viagra, you can get this bluish tinge or hue in your vision that's temporary. All of the side effects are temporary. They wear off when the medication wears off. But it's important to know that they're not uncommon, but usually they're temporary and they don't last forever. And oftentimes by decreasing the dose, it can help mitigate the side effects. Important thing, if you're on any kind of nitrate, so oftentimes those are heart medications or blood pressure medications, it's a specific type, any kind of nitrate or any kind of alpha blocker, which is usually Flomax, so a medication that you're taking for your prostate. The Flomax, not so much. I actually have plenty of patients on Flomax that take Cialis as well and have no issues. Nitrates is a hard stop. If you're on a nitrate, what can happen is taking a Cialis or a Viagra can lower your blood pressure enough to where it's in an unsafe level. So I do not let, or it's actually contraindicated to take Cialis or Viagra or a PDE5 inhibitor in a guy that's taking nitrates. So that's important to note. So interesting fact is 50% of guys who try oral medications actually will give up on the pills when they stop working. And I think that's important to note because a lot of guys don't know that there's anything else out there. And oftentimes they'll go to their primary care physician and say, I'm interested in erectile dysfunction treatment. They tried the pills, it doesn't work. And they say, well, I guess that's a part of my life I won't get back anymore. And so I think, and we'll talk about this in just a second, that's important because there are other things out there. And then again, diabetes, I keep harping on the diabetes because it's one of the most important risk factors for erectile dysfunction. And guys with diabetes are much more likely to move on to other therapies than men with other potential etiologies for their erectile dysfunction. And so we talked about all these essentially, but I apologize. So the next basically option that I'll talk about is called intracavernous injection therapy. So ICI is what we call it. The idea is basically the patient will inject a liquid form of certain medications that induce artery dilation directly into the penis. And so I always tell guys, inject it about 5 minutes before you're interested in activity or sexual activity, whether that's intercourse or masturbation. And it's quite effective. So the success rates are very, very high because there's different concentrations of the medication. And so basically we customize the medication to the patient to make sure that we get enough to get you an erection. The issue is, as you could imagine, taking a needle to the penis is not the most desirable thing and not the most romantic thing either. And so there's quite a few guys that do try ICI, do try intracavernosal injections and stop doing it because it's not the most pleasant experience. I have actually plenty of patients that have no problem with it and swear by it because it's what they know, it works and it's great for their sex life and they're okay with being able to do the injections. So I have plenty of patients that this is what they do. This is all they want to do for the rest of their life, which is totally fine. But there's quite a few patients, the data says about 40% that'll stop it pretty quickly after starting because of the fact that it's just not super comfortable. The most common side effect is this ache in the penis that a guy will get afterwards. There's a specific medication that can cause artery dilation to the point where it gets a pretty bad ache that can last sometimes even an hour or two after the injection. And that's not from just the needle poke, it's from the actual erection. And so usually the reason the guys will stop is either they don't like the injections or they're having pain with it. And some guys stop it because the medication has stopped working. And so, this injection therapy, it works fantastic for the guys that it's good for, but the cons are the fact that it's a needle into the penis. And so then the next option that we'll talk about is the vacuum erection device. So this is basically glorified penile pumps. The idea is you put a cylinder on top of the penis, you put a band at the bottom of the penis, you create a suction basically with that vacuum, and it essentially pulls blood into the penis to give you an erection. It's effective in men that are willing to use it. So it can be, sometimes even up to 3/4 of guys that have some aspect of success in terms of increased rigidity of the penis because it pulls blood into the penis. There's a band at the bottom that's keeping the blood in it. Problem is, you can get bruising. It's a cumbersome process. It's not super comfortable. Some guys find that there's a little bit of penile numbness or decreased sensation with intercourse. And so a lot of guys try this and then discontinue it, mainly because it's not super comfortable. It's not the most pleasant process. And then with that band on there, it's not the most comfortable process during intercourse or during ejaculation as well. Interestingly, in a lot of my post prostatectomy patients, I'll actually have patients take Cialis, take Viagra, take some of the oral medications, and then use a vacuum erection device to try and augment that. And that's because oftentimes after prostatectomy, it will dilate the arteries and a little bit more to stretch out any kind of scar tissue or fibrosis that is formed after the surgery. So I do use this. And then, along those lines, after prostate surgery, I know that a lot of guys will have issues with penile length. I know there's a question in the chat about this, and that works in perfectly right here. So after prostatectomy, guys will get a little bit of a lack of tissue viability, tissue robustness, because you're not getting as many erections as you did before, but also because when you're cutting that urethra out, you do have a little bit of shortening. And so I actually have I always have most of my guys, if not all of my guys, post prostatectomy, take either Cialis or Viagra, ideally daily. I usually have them on a daily Cialis along with Cialis or Viagra as needed, whether or not you're sexually active with a partner, meaning if you're single or if you're not sexually active with your partner, just to have an erection, potentially even ideally once a week, to go to bring blood flow into the penis, not only to improve those blood vessels to try and regain erectile function, but also to help to maintain length of the penis and maintain girth, because by increasing that blood flow, it keeps that tissue viability, for which elasticity is important. So elasticity is the important part for penile length. And so to kind of answer that question, yes, absolutely, using Viagra, Cialis, etc., plus or minus a vacuum erection device can help with maintaining or at least improving that penile length loss that occurs after a prostatectomy. So the second to last option is what's called a urethral suppository. And so basically the idea is, and there's actually two versions of this. There's a kind of a little suppository version, and there's a liquid version. But the idea is taking this medication and placing it into the urethra, so into the P channel, to get an erection. The effectiveness is a little less than the injections and a little less than the vacuum. And the main side effect is this urethral discomfort. So discomfort or pain within the urethra. Most commonly, the reason the guy is going to stop the medication is because you're not getting a good enough erection, but also because of that discomfort of placing the medication into the urethra and that burning that about 10 to 15% of men will get with using the suppository. So this is actually an option that I don't use too often unless a patient has used the injection and is not either doesn't want to use the injections because of discomfort, or if the injections haven't worked and they're not a candidate or don't want the penile implant surgery, which we'll talk about in just a second. So again, this is something that I think is an important part, and I have a small population of patients that use the urethral gel, the urethral suppository, and have no issues with it. But to be totally frank, I don't have a ton of patients that use the urethral suppositories. So then the penile implant. The penile implant's the last option. And I'll stop for a second. My trajectory through these treatment options usually goes with oral therapies, and then it'll go to plus or minus the vacuum erection device. I know it's a little out of order in this slide deck. So oral therapies, plus or minus vacuum erection therapies. I'll talk about the suppository at that point, but usually we're moving on to doing the ICI, the penile injections. And then this is the kind of the last step. This is the end all be all. So what happens is, basically the penile implant takes fluid from a reservoir, and then I'll talk a little bit more about, at least there'll be a little bit of video that describes that in more detail. Fluid from a reservoir, brings it into the penis, and the way that a man does that is you take this pump that's in the testicles, you can see in the picture. With that pump, you pump up the cylinders that are in the penis that bring in the fluid from the reservoir, and it gives you an erection, and then you're able to go back to being flaccid or being soft by pressing a little deflate button on the pump. So basically, long story short, to get an erection with the penile implants after the surgery, you take a pump that's almost like a third testicle, you pump up the implant, and then when you're done using it, you press a little button that's on top of the pump, and it deflates the implant, and that's it. The great thing about the implant is it's 95 to 98% effective, meaning 98% of guys are happy with the implant, are satisfied with the results, and have no issues with it. And the important part about it is it doesn't affect your sensation. It doesn't affect your orgasms. If you had ejaculation and orgasms before, you'll continue to have them after the implant. And after you've recovered from the surgery, there's not really any major issues with having an implant in place within your body. And so the important thing to note is you're going to maintain everything from a erectile, orgasm, ejaculatory standpoint. The only thing that's changing is you're not using medications or injections. You're just pumping it up whenever you want it. And then when you're done, take as long as you want and you deflate the penis, the implant. Most common side effects. So the most important thing that I tell every patient that's thinking about a penile implant is infection is the number one risk with it. Any kind of foreign object that's going into the body, there's a risk of infection that can range from 2 to 4% with penile implants. The risk is a little bit higher with guys that are diabetic. And so the important thing with the penile implant is if you're thinking about it, I usually want my patients' A1Cs or hemoglobin A1C levels, diabetes levels to be under 8.5. That's the number that reduces risk for potential infection with a penile implant with diabetes. The other risk is, having some kind of discomfort afterwards, genital discomfort. Some patients, that discomfort can last for about 4 to 6 weeks, and potentially sometimes even longer. It's pretty uncommon. Usually I tell guys you'll be a little sore for about 2 to 4 weeks. I'll give you pain medication, and as everything heals up, that subsides on its own. And the last potential side effect or complication is malfunction. These devices can last upwards, sometimes even of 15, 20, even 30 years. I actually had a gentleman recently that I replaced his device who's had it for 26 years and put a new one in because it finally had some kind of a malfunction. And so they can last for quite a long time, but they can't have malfunctions where I have to go in and replace the device. So with the penile implants, there's 3 main types. There's a 3-piece implant, a 2-piece implant, and then a malleable. The 3-piece implant is the most common. That's the one where you have the pump in the scrotum that you pump up, the cylinders in the penis that pump to give you an erection, that deflate to get rid of the erection, and then the reservoir. The reservoir houses the saline. That goes basically behind the pubic bone. It hides, you don't feel that or anything. That's the most common implant that I recommend to most patients. The 2-piece implant basically has just the cylinders and the pump. The only problem with that implant is it doesn't deflate super well to where a lot of guys will feel it pretty regularly. And so I usually don't recommend that one unless for whatever reason, the abdomen, a guy's had a ton of surgeries where I can't place the reservoir somewhere in the abdomen, or if they've had, plastic surgery or something like that. The malleable one, all the way on the right, that's basically I tell guys it's almost like having a glorified pipe cleaner in the penis, meaning it's a flexible but somewhat rigid cylinder that goes into the penis that basically stays semi-hard all the time, but you can bend it down and bend it up whenever you want. And so it stays essentially the same size, but whenever you're interested in sexual activity, you bend it up, use it, and then when you're done, you flip it back down. That's when I usually only recommend in patients that have issues with hand dexterity, that are going to have problems with being able to pump that pump in the scrotum. And so this implant that to Boston Scientific, who's hosting this event, I use their implants pretty often with most, if not all, my patients. And their implant is the only one is one that has basically a built-in antibiotic treatment. And so basically, it's got this what's called inhibizone, which is essentially 2 antibiotics, rifampin and minocycline, that's impregnated into the device itself, so that infection risk is decreased significantly by using this implant. So I do a bunch of stuff during the surgery to reduce the risk of infection, including cleaning you with a special soap before the surgery, and during the surgery, I give you pretty heavy-duty antibiotics. And then having this built-in antibiotic, the inhibizone, is for me puts my mind at a lot more ease, because there's studies that show that it reduces the risk of infection pretty significantly. The implant is fantastic. Basically, it's got this what's called an MS pump, the momentary squeeze pump, where it's super soft. It's not difficult to pump, and as soon as you pump it, the fluid goes from that reservoir straight into the cylinders. It's easy to use. It's essentially rock hard when it's fully rigid, and then it takes about 15-ish pumps to get to the point where you're pretty much fully rigid. I usually tell guys 15 to 20. And the most important thing is whenever you deflate that pump, it gets you down to a pretty natural looking flaccid penis pretty easily and quickly. It's been around for a long time, and a lot of guys are running around that have this implant, and you'll hear from one of them a little later here in this talk, that are pretty darn happy with the results they've gotten with the procedure and with the implant. So basically a short video on how it works. I'll let the video play here. Sorry. Well, I apologize. I may not be able, well, there it goes. Okay, perfect. Well, maybe not.
If you move on, I can pull it up in a separate window.
Yeah, I apologize. Yeah, I'll move on and I'll pull it up a little bit later. I apologize. I'm not sure why that's not working. So real quick to talk about the procedure itself. The implant is usually performed outpatient. So it takes me about an hour or so to place the implant in. I use an incision that's in the scrotum that's about 5 to 6 centimeters after you're asleep. I place the implant, all three parts of the implant I place through that small incision to the scrotum, unless you've had some kind of abdominal incision. Oftentimes then I'll use another separate incision that's right above the pubic bone to place the reservoir underneath what's called the fascia. I usually tell guys about a week or so of taking it pretty easy to getting back to basically your regular routine of light activity. So that's about 4 to 6 weeks, though, of taking it pretty easy from a major physical activity standpoint, including sexual activity. So I have you, avoid any heavy lifting, running, exercising, significant exercising. Walking is fine. Stairs are fine. Normal daily activity is totally fine. But 4 to 6 weeks of taking it pretty easy from a major activity standpoint, major physical activity prior to going back to normal. And then about 4 to 6 weeks before being able to have sexual activity as well. So usually what I do is I'll do the surgery. I have you come back. The next day, I usually leave a catheter and a drain in place for about 24 hours, and I remove those the next morning in clinic, as long as you're going home from the surgery. 2 weeks later, I do a little incision check, make sure the incision looks okay, make sure you're doing okay from a post-operative standpoint. And then at the 4-week mark, I have one of the Boston Scientific reps actually spend a good amount of time with you to talk about the pump, do some teaching with you, some one-on-one teaching about how to use the device. And then after that, at about 2 months, I have you come back to me, make sure you're doing okay. And that's about it. So cost. A lot of guys have an appropriately important common question about cost. So insurance coverage for most ED treatments vary. But the important thing is oftentimes the implant is covered. It'll be covered by insurance, including by Medicare. And so obviously it depends on the insurance, but I think the take home from this slide is it can be affordable. The implant is not something where you're going to be breaking bank usually by any means to get that covered. So I think that's a very, very important thing to note. So the benefits, again, it's most patients are extremely satisfied. And the other important thing is most partners are extremely satisfied as well. With the implant, it's usually covered by insurance. It lasts for years, potentially up to even 20, 30 years. And it fits into the penis. It's custom fit into the penis to be able to, and designed to be able to be used as a natural looking erection, but also as a natural looking appendage, meaning when it's flaccid, it doesn't look like you've got an implant in. You can use it from a urination standpoint without any changes or issues at all. And the other important thing is it can be as spontaneous as you want it to be. It takes about 30 seconds to be able to pump it up to get it to fully rigid. And then whenever you're done, you take it away. And a lot of guys swear by it because of the fact that they went from not being able to get an erection without pills, without injections, to being able to get an erection essentially on demand, which is a huge change. Most important slide, I think, of the entire penile implant thing. There's risks involved with any surgery. And so if you're going in to see your specialist to talk about an implant, talk about the risks and make sure you delve into this because this is super important. Again, infection is a big risk. Mechanical failure of the implant is a big risk. Both of those would mean that you have to take the implant out and put another one back in. You can have post-operative pain afterwards. Sometimes that can last even up to 2-3 months. Not likely. Usually it's about 2 or 3 weeks, but it can last longer. Guys that are diabetic, guys that are immunodeficient are more likely to have the risk of infection. Infection is the biggest risk. And I know I've said that, but I'll say it again. And you can't, this is the most important thing. I custom fit the implant to what your body gives me or what your body gives the surgeon. Meaning I tell guys, I take the penis flaccid, I stretch it out, and at the full stretched length of the flaccid penis, about a centimeter less than that, that's going to be what the size of the erection will be with the implant. We can't unfortunately make the penis any bigger with the implant. We put it in and use the tissue that you already have within your body to put the implant in and make it that size. And so unfortunately, we can't make the penis any bigger or wider than it was before, but we custom fit the implant to use every inch that you have so that the implant is able to use the space that it needs minus about a centimeter or so of length. So overall, erectile dysfunction, it's a common problem. There's a ton of treatment options that are out there, as we talked about today. And the important thing to note is seeking the potential treatment options, not only from erectile dysfunction, but also seeking care or treatment for the potential etiology behind the erectile dysfunction is unbelievably important. I cannot harp that enough. And among those options, the last option, but potentially a great option, is the penile implant, because it lasts quite a long time. It's super satisfactory to most patients. Most guys are extremely satisfied and they have great results from it. And so, from an erectile function standpoint, there's a lot of references that are here, but I'm happy to be a resource for you at any point. This is my clinic information. Both my clinics, one in Fairview Heights, that's the phone number there, one in St. Peter's, that's the phone number down there. And Mike will send this out to you as well. But I do want, before I set this up for questions, Cliff is one of our former patients who's had an implant, who's here to talk to you about his experience. And Mike will introduce him here in just a second.
Yes, I'd like to introduce Cliff Pollock, who will take you through his diagnosis of and journey through treating erectile dysfunction.
Yes, good evening, everyone. My name is Cliff. Basically, my story is very simple. When I was 57 years old, I was diagnosed with prostate cancer. And with the prostate cancer, I decided that the best thing to do was to have a prostatectomy. So I had a prostatectomy done, and needless to say, ended up with ED. Went back to my primary physician, and they put me on Viagra. And my response to Viagra was exceptionally bad. I got headaches that was so bad, I just had to put my head down on a pillow. I just couldn't get up. They transferred me over to Cialis. From there, we went to Levitra, and we did this for a whole year. And in that whole year, even though I used it correctly, I never got an erection and just got terrible, terrible headaches from all of the 3 pills. Went back to my primary, and he suggested this vacuum device. Bought the vacuum device, and I will tell you the vacuum device worked, but I will also caution you, you don't want to go to a sex shop and buy a $25 vacuum device. You want to get a prescription from the doctor and go to a medical supply house to get a good vacuum device. The vacuum device I used for about 6 months, and I will tell you it worked. The only problem with it is your penis becomes a little cold. It turns a little blue, which is really a very big turnoff to your partner. And taking the band off of it, they call it a band, I call it a tourniquet. Slipping it up the shaft is not hard, but getting it over the head hurts. So after 6 months, I gave that up. And then I had no idea what else to do. So I went into a major, major depression because at this point I had lost my manhood. It was as simple as that. Luckily, back then they had meetings, and I was invited to a meeting to learn about some other treatment options for ED. And I heard about the Muse, and I also heard about the injection therapy and about the implant. My wife and I talked about them all, and we decided on the implant. And the day after my 60th birthday, I did the second best thing I ever did in my whole life. I got the 3-piece implant. I will tell you, I had that implant for 14 years. Finally, it did give up. And after the 14 years was up, 2 years ago, I had it replaced. So now I've got the implant going on full 17 years. It has never, ever, ever failed to give me a solid, rigid erection, good for any type of intercourse you want to have. I will tell you also, when you go to the prosthetic urologist, like Dr. Islam, it's good to take your partner with you, because ED is truly not just a male issue, it's a partner's issue. It takes two people. And I heard so many stories of guys telling me, you know, my wife thinks I'm having an affair with somebody. I don't love her anymore. I don't find her sexy anymore. And that's the furthest from the truth. So the sooner you can get your partner involved in what really is happening, I think the easier it is to transfer to the three-piece device. And I will tell you, my wife has said many, many times, if she did not know I had the device in me, she really couldn't tell that there was an artificial penis inside of me. Pumping it up is very simple. Basically, during foreplay, all you do is reach down and 15 to 20 pumps, you're set for the night. You truthfully become the Energizer Bunny. You can say as hard as you like for as long as you like. And it's really kind of, when you think about it, it's kind of very good, because most men will reach orgasm before their partner does. And this way you can stay rigid and get your partner to have a really good orgasm and have a lot of fun. I will tell you, people ask me, are there any drawbacks to it? The answer is absolutely none. I've never found a drawback to it. After 6 weeks, I had healed pretty well. After 6 weeks, we went back to having intercourse again. And I will tell you, we did have some type of sex, but a lot of the intimacy was lost when we couldn't have sex and I couldn't have erections. And it really brought back an intimacy that we had lost. The other thing is, people ask me, well, what happens when you go through the airport? Does the alarm go off? Well, no, the alarm doesn't go off. It goes off for me because I have 2 artificial knees. And then they take you over to this little curtain and they take this wand. I don't know if you ever been wanded. And they run the wand up and down your body and in your inner thigh and around your crotch. And nothing, it's silent. So nobody can tell. I went back to working out after 6 weeks. I work out with 3 guys. We shower together. They had absolutely no idea there's anything inside because it is so natural. The other thing people ask is, well, can you still get MRIs and CT scans and PET scans and CAT scans? And the answer is yes, it doesn't stop any of that. And the one final thing they ask me is, well, how does it have any effect on your urination or bladder function? And the answer is absolutely none. You have no problems at all with that. So basically, after 3 years, I'm now 76 years old. I've had this one for 3 years. If I live another 14 years, I'm going to get another one. Simple as that. It really does change your life and really makes you back into a whole man again. Your manhood is returned. So I will turn it back to everybody. If they have any questions for the doctor or me, that's fine. It's all yours, Mike.
Yes, we had some pre-submitted questions. The first is about pills and specific difference. So if someone took a pill, one type, say Viagra, that doesn't work, is it possible that another pill option might work for this patient?
It's a good question. And yes, it could. There's certain patients, for whatever reason, that one pill is more effective than the other. The most common often reason is with Viagra and Cialis. Cialis is not affected by food intake, whereas Viagra is. But there's in certain patients, the food intake, the time before taking the Viagra can vary. And so Cialis, I oftentimes have guys that come in on Viagra that I switch over to Cialis, and there's more effective Cialis than the Viagra, or vice versa. And there's other medications, kind of like Cliff was alluding to, like Levitra, and then Stendra is another one that some patients, for whatever reason, have a better effect to than others. But also, sometimes patients can have side effects, again, like Cliff was alluding to, that are pretty significant that can keep them from taking the medication, that for whatever reason they have the one and not as bad as the other. But, just like Cliff was saying, there are patients that, do have pretty bad side effects that get to the point where it's not an option for them. So, yeah.
There's a question about the implant, specifically about post-surgery and the scar that's left. Is there a large or noticeable scar?
Oh, sorry, you said scarring after the implant?
Yep.
Got it. Yeah. So the only scar is on the incision is on the scrotum. Basically, it's if my finger is the penis and then my fist is the scrotum, the incision that I make, at least on my implants, is basically right where the scrotum meets the bottom part of the penis. And so then that scar over time heals enough to where most guys actually can't see, or it's very difficult to see where that scar was prior. And I think, Cliff, potentially, if you want to answer that question, just talk about, if you can see where your scar is or not, I think that'll help too.
Yeah, no, I can't see my scar at all. It was gone after about 4 months. We had to search for it.
Yeah, it's usually the common scenario is that a scar disappears after a few months. Some patients, we do have to make 2 incisions, one in the scrotum and one in the abdominal, the lower abdomen or the suprapubic area to put that reservoir in. And same with both of those scars. They both essentially disappear, or at least you have to search pretty hard for them over time.
Okay, thank you both. Now a question about the sensation. So when the implant's in, is it possible that will dull or reduce sexual sensation?
And Cliff can allude to this, I'm sure, in real time, but no, it does not. Do you agree with that, Cliff?
Absolutely. My orgasms are just as good as they were before when I was 18 years old, except the fact that without a prostate, as my wife says, there's less cleanup. But the orgasm for me is perfect. It's very, very, very vital and very good.
Now, for somebody who wants to get a hold of you, Dr. Islam, what's the best way to do that?
Yeah, so the best way would be we'll send out an email with my information, but to call one of those numbers to my clinics. And so basically, if you call the clinic, the easiest way is to call the clinic, basically get a hold of my scheduling staff, and they can get you an appointment to come see me either at Fairview Heights across the river in Illinois or on the St. Louis side at St. Peter's. And so, yeah, those are the 2 great options. And then there's another question in terms of that's come up in the chat about taking Viagra after surgery. So the question basically is, if you've had a prostatectomy or a prostate cancer treatment, is there a certain amount of time after that treatment that it's too late to take Viagra or Cialis to try and get treatment option or to try and get a response? And no, not necessarily. There is not. You can absolutely start taking Viagra or Cialis anytime after prostate cancer treatment. What I will say is usually after prostate cancer treatment, you get the best response by starting the medication pretty quickly afterwards. It's not that you've burned any bridges by not taking the medication right after the procedure, but you get usually the best response or the best potential for regaining the erectile function. That being said, if it's been 2, 3, 4, 5 years, you can absolutely take the medication and take it either daily or as needed to see if there's a result. And sometimes over time, potentially by taking it daily versus as needed, you can get a steadily improved response. However, usually at around the 1.5 to 2 year mark, you're essentially at that's as much improvement as you'll get if you started taking the medication right after the prostate cancer treatment, meaning the nerve regeneration, the nerve healing process, usually after about 1.5 years has completed. And so to answer the question, long story short, you can absolutely start taking the medication to try and get some benefits from it, years after having that surgery. The question ends up being how significant those benefits will be.
And there's a final question here is about using the implant and if it's complicated. Is that something where normal person would have trouble figuring out how to operate?
Yeah, no, I don't think so. I mean, speaking as the person that puts the implant in, I try and place the implant at the most dependent part of the scrotum, meaning at the very bottom of the scrotum, in a place that's very easy to palpate. So it's easy for a patient to tell exactly where it is, but also because the pump is so easy to compress, essentially, it's not super difficult to operate the device in general. And then Cliff can tell you kind of the real life experience on that and what his thoughts are.
Yeah, it's very simple. It's not hard at all to press and to squeeze. As a matter of fact, my wife has asked, can she do it? And the answer is yes, she's done it a few times. I will just make one comment about that. I will warn you that if you give your partner your scrotum in their hands and that you know what's going to happen, it cost me 2 remakes of bathrooms and a kitchen. But yeah, it's well worth it. But anybody can, just squeezing it and getting the erection is very, very simple, and anybody can do it.
Well, that concludes questions. I'll put a last call in here. But in the meantime, I want to thank you, Dr. Islam, and you as well, Cliff, for sharing all the information tonight. And thank everyone for attending. We will send out an email tomorrow with Dr. Islam's contact information, the webinar recording, so this link if you want to rewatch, and then information on how to make an appointment. Any final words to leave with the audience?
Not at all. First of all, I appreciate you taking the time on a Tuesday night to spend time with us to hear me and hear Cliff talk about erectile dysfunction. But if you have any questions, if anything comes up, if you want to come in and chat, please, by all means, feel free. I'm happy to be a resource. I'm happy to have y'all reach out and ask any questions at any time. And I'll be doing these probably throughout the year. So if you have other questions or you want to hear more information or want to hear the talk again, I'm absolutely around to be a resource for you.
Thank you both. This concludes tonight's Men's Health webinar.
Cliff, thank you so much for being here. I appreciate you.
Very welcome, sir.
Good night.
Have a good night.
Good night.